The opinions expressed by the host and guests in this show are not necessarily the views of Children's Health Defense.
Good morning, CHD. It is Monday, the 31st of March, 2025. We're live here at CHD TV. Right, so first up, the medical records from the girl that the press said died of measles have been handed over, signed over by the family to Dr. Ben Edwards, Brian Hooker, Dr. Pierre Kory, and Dr. Suzanne Humphries. All four of those people have the medical records, as I said, signed over by the parents to those four people. We are going to go through some of those medical records this morning. I'm going to bring on two of the best doctors, in my opinion, in the whole world, Dr. Suzanne Humphries and Dr. Pierre Kory. Welcome to Good Morning CHD. Dr. Kory, I'm going to start with you because, interestingly enough, in the press is still full of measles, and that measles is a killer worldwide, with all of that kind of stuff. But what is not in the press in the last few days at all is that there was a little girl that died of measles. It's gone. Because she did not die of measles.
So we corrected the record. Well, so the truth still matters. I guess facts still matter. But the problem was getting the facts out, right? And I want to just be clear that I think the work of, you guys at CHD who really went down there to try to find out what was really going on and what the truth was, and to support the family. And I think through that support, they graciously and I think correctly released the records to you. And obviously I reviewed the records. I've spoken about it before, but I'll just summarize. Basically, from what I understand from Dr. Edwards, because I didn't have an outpatient record, but apparently she was improving from the measles. The measles rash was resolving, but then she became ill, started coughing, and was getting short of breath. When she arrived at the hospital, I'll give them credit. They made the absolutely correct diagnosis. Right on the admission, it said secondary bacterial pneumonia. And, I make the point that that's independent of measles. You can get secondary bacterial pneumonias after any infection. I myself have three daughters. One of them had a secondary bacterial pneumonia after a flu when she was like 14, which we easily treated. The problem was that although they made the correct diagnosis, their initial antibiotic choice was inappropriate. There are guidelines from almost every major professional society on what antibiotic regimen you give someone when they arrive at the hospital. So now they need hospitalized care, which is obviously a higher level of severe than if they were still at home. And that combination has been pretty standard for a long time. And the reason why you use that combination, which is basically a combination of like a penicillin-like agent and like a macrolide, which is like an azithromycin-like agent. You can also use quinolones, but you want to have that combination because they work very differently. And there are different organisms in the community. We can predict them with pretty high accuracy because they commonly circulate. And for whatever reason, they chose two kind of what we call beta-lactams, which work the same as penicillin. And the reason why that's inappropriate is because one of the most important community-acquired pneumonia organisms is something called mycoplasma, which doesn't have a cell wall. So you need to use an antibiotic that doesn't work by destroying the cell wall. Azithromycin or Z-Pak disrupts protein synthesis. And unfortunately, they didn't use that. And so it was a deviation from standard. I think it was an oversight. I try to put myself in the mind of the doctor, and I think, they probably they had maybe a good intention, which is they used vancomycin, which is although it's a powerful antibiotic and it's directed at multi-drug resistant organisms. So they might have felt like we're going to be really aggressive with this patient, maybe because they had concern for how ill she was. The problem was that scientifically and clinically, that was the wrong choice. And the problem then became is that, and by the way, when you choose antibiotics, you don't know what the organism is. So it's called empiric treatment. But you do test to try to identify the organism so you can narrow your antibiotics. And, they did send the test. She was admitted. And really, the second misfortune that befell her in terms of the medical care that was delivered is that she continued to decline over the next, I think, 2.5 days. And, that's another thing in medicine is that when you see someone not responding to your treatments, you really have to kind of go back, review, what am I missing? What can I do differently here? And I didn't see that happen until the test for mycoplasma came back. And it came back kind of in the middle of the night. An antibiotic was ordered. The azithromycin was ordered. That was appropriate. From the record, it doesn't look like she got it until the next day, although I think there's also a little deficiency of documentation, but it looked like it was another 10-hour delay. And unfortunately, by that time, she required a mechanical ventilator, which is what happens when you have an underlying illness that's not being appropriately treated. That's going to just continue the trajectory of decline. And she certainly declined onto a ventilator. I think the decision to put her on a ventilator was appropriate and was appropriately timed. They tried non-invasive first, and then they intubated her. And then, unfortunately, less than 24 hours later, she died of catastrophic multi-organ failure. There was some sudden catastrophic event. I don't know what it was, but I don't think that's important. I think what's important is that event could have been avoided with appropriate treatment, and unfortunately wasn't delivered. And I just want to share my sentiment with the doctors involved. I've made mistakes in my career. I've been fortunate that those mistakes did not lead to grievous harm. But if they had, I will tell you, it would affect me deeply, and I think really be psychologically traumatic. And so I feel for everyone involved, obviously the parents and the child, but it's a sad case.
Thank you. Okay, thank you for that. Dr. Suzanne Humphries, if you could tell us what you found as well, that would be great.
Thank you. Yes, well, there were 211 pages to go through. Unfortunately, what was lacking in my version of the chart, and I don't know if that was the case for you, Pierre, but normally when I worked in hospital medicine, an essential part of the chart would have been the drugs that were given, the nurse that signed off on them, the time that they were given, and that they were actually given and not just ordered. Because you can have an order, it doesn't mean the drug is given. So there are probably half the chart is orders. But I didn't see anywhere.
That's where I was I'm sorry, that's why I was making that point, that it's hard for me to tell when it was given. I didn't see an actual, delivered or infused. But one of my concerns, and I'm sure you looked at this too, Suzanne, is that I could see that the order went in at 11:37 at night, but it looks like the first dose was set for 0900 the next day. It was not like on that calendar day that the order was in, the first dose was not ordered for that day. And so I don't know how long that delay was, but it's unfortunate. It should have been stat. I mean, in an ICU, it should have been stat. We have standards in ICU for how quickly antibiotics are delivered. I mean, generally, it should be there within, I think, an hour or two. I can't recall what our policy was at my old ICU.
Yes, and there was also some comment about how she was sedated while she was on the non-mechanical ventilator, because basically being, with the what's it called? Were they
like a BiPAP,
non-invasive
mask? Yeah.
But it's masked with pressure and it's uncomfortable, and she was unhappy with it and she was struggling. And it looked to me from the comments that she was sedated. And okay, so you've got a stressed out child, you're talking oxidative stress, you're talking psychological stress, and then she's sedated, which is something you really, in my opinion, you don't want to do unless you're actually about to put someone on a mechanical ventilator, because we know that sedation can lower the respiratory rate and it can change how you're breathing. So I would really like to see which drugs were given, just so that I could look at that. I would like to see how many doses of vancomycin were given, because, and again, correct me if I'm wrong, Pierre, because you're the intensivist, but when I was consulted in intensive care medicine, once you got that MRSA negative test, you would stop the vancomycin, right? So if they wanted to cover gram-positive, they could have just done that, because we know that vancomycin can be a very toxic drug, which is why we check the trough level. A trough level was checked on her very last day, right before she died, is the first time they checked a trough level. And indeed, it was on the low side of normal, where you'd want to see a trough, but How many days had she been given the vancomycin? I don't know, because we weren't given that information. How many doses of acetaminophen was she given? I don't know, because we don't have that. All we have are the orders, and it would be really good to see what doses, what drugs were given, and also if they decided to give her any vaccines while she was there, because we know that hospital policy can dictate such things. So
Yeah.
I would really like to see that part of the chart. But I echo what Dr. Kory said in the sense that we're not here to throw doctors under the bus. What I really want to look at is systemic failures, hospital systemic failures. And I think that we're looking at a system that does things out of eminence rather than evidence. Okay, so, and this is very easy to prove, especially if you just look at what medical literature actually shows and then see what standards of care are. Oftentimes it's the exact opposite. So I'm just going to summarize how I see the problems that happen with this child, because I would like for people to understand more broadly how things could be improved for every hospital in the world. So first off is that they were too slow to diagnose. The unnecessary antibiotics weren't stopped. The necessary one wasn't started till she was nearly dead. But any antibiotic, and this is something, I don't know about you, Pierre, but I never saw this stressed in the hospital system, which is that bacteria secrete endotoxins and exotoxins, and all we're taught is that that is their mechanism of problems, and that we can throw steroids on them, we can give mechanical ventilation antibiotics, but we are never instructed or encouraged to read more broadly on other drugs or supplements that can neutralize toxins. And one of the most underutilized chemicals on the planet is ascorbic acid. We know that that is a toxin neutralizer as well as everything else. And I'm going to get into a little bit more into vitamin C in a minute. So I just think that, I don't know about you, Pierre, but did you stress that with medical residents when you were teaching? Was it stressed to you?
Of course. I mean, once I discovered, that was my work with Paul when, especially his protocol, once I discovered what higher doses of intravenous, it has to be intravenous. I mean, oral vitamin C in someone critically ill does not a whit. But when you're talking about intravenous vitamin C, I mean, it can reverse multi-organ failure, it can prevent multi-organ failure by addressing that endo and toxemia. And, I've seen it work at the bedside. I mean, it's literally eye-popping. And I hate to end this statement with it, but that's been disproven, right? Since Paul's study came out, it's the same thing as ivermectin. I have a chapter in my book on ivermectin called The Big Six. Big, large, I'm using air quotes, rigorous, high-quality trials showing ivermectin doesn't work. It's the same pattern. They did the same thing after Paul's study. Suddenly, the academic medical centers started churning out IV vitamin C, and now it's not standard of care. So I like that you picked up on it. I think I'm just so numb to how suppressed, therapies that don't bring the incredible profits, but have strong physiologic and clinical basis, they're just not incorporated. You go into hospitals now, because people ask me to consult on hospital cases, and the times that I've tried to talk to clinicians, say, please start IV vitamin C on someone is critically ill, and I'm met with, no, it doesn't work. We don't do that here, and I won't do it. So I'm glad you're bringing it up, because I've kind of resigned myself to they win that war. And it's just sad, because I think you're right. That would have been another opportunity to potentially have prevented her decline and saved her life. I've seen it.
Absolutely. Especially when you go through the chart and you see that she was actually pretty stable on day 2. She was asking for food. Day 3, she was semi-stable. So there was actually a lot of time to do interventions. And so, when I was dealing with measles in 2019 in outpatients who were extremely sick, I remember one boy was brought into my office and he sat in my chair, and I thought, oh my God, this kid is going to die in my chair. He's going to die in my office. He was so sick, and I was quite frightened. So I put him, my standard was 500 milligrams per kilogram intravenously over about 2 hours was what I gave. I'd say within 30 to 40 minutes, that kid perked up in that chair. His rash changed before all of our eyes. And by the end of it, he was sitting there on his phone, and it was absolutely related to the vitamin C. And then I started to get really angry, because I just thought, it's this easy? It's this simple? Here we are told you can do nothing about measles except prevent it. And here's a kid that was clearly on his way to being septic. His skin was purple, actually. And he recovered in the chair. The second day, he came back for his second infusion. By day 3 and 4, he was just about back to absolute normal. Now, if he went to a hospital, would he still be here today? because what they do is they carry on piling on drugs, causing liver toxicity that's exacerbated by the things that they do. And even in this child, somebody read her I believe it was a chest or abdominal x-ray. By the way, the feeding tube was, no, I'm thinking of am I thinking of this one? Yeah, she had a feeding tube, and they told her, they said that it needed to be more advanced, that it was actually sitting in the distal stomach and should have been advanced to duodenum. But anyway, at the time, they said that there was hepatosplenomegaly. But does anybody think about that? Do they just go, oh, it must be because of measles? No, hepatosplenomegaly. This child is under stress. She's toxic. Her liver's not keeping up. So what do? We're dehydrated. Okay, they gave her fluids, fine, but probably not enough fluid, especially beforehand when she was begging for water and she wasn't getting water, because that was kind of a critical time where she should have been given that.
Yep.
But if you add on the liver toxicity from the drugs, and which I'm going to get to in a minute, but you say, and this is what they do, is someone comes out with a study, and Meryl Nass talks about this, that she came out with a study, she showed something to be true, and she said, her exact quote was, the pharmaceutical industry buried me with all kinds of research to counter what I said. And that's exactly what's always happened with vitamin C. It's been going on for, I think, about 70 years now. But we've got people like Harry Hamila, I believe he's from Finland. We've got Paul Marek, who's USA. We've got Margaret Vissers and Anitra Carr from Dunedin in New Zealand. Today, these are people that are still with us, that have done really great studies showing the benefits of vitamin C. And we've got Dr. Fred Klenner from the past, who was an absolute, he was amazing. All the different documented illnesses that he purported to cure. Nobody argued with him. When he would bring it up at meetings, he said it was just absolute silence. Nobody had anything to say about it. So, and again, Harry Hamila talks about how, most of the articles that come through and say it's of no benefit is because they're not giving enough. And I know there's a case in New Zealand where a cattle farmer, who I happen to know personally, brought his sons had to bring in, everybody knows this case is Smith. I'm trying to remember his first name.
Alan Smith, yeah.
Thank you. So his son had to pay the most expensive attorney in all of New Zealand to come in and argue to get him IV vitamin C. They gave him, I believe it was a meager 25 grams, which was like a miracle. And then they stopped giving it once he started getting better, and they had to call her back in to give more doses. So it's that difficult. So if you can't afford the most expensive attorneys to go to bat for you and could get there in time, you could really be up a creek, despite so much medical literature that speaks to the benefits of vitamin C and sepsis, and the sequential organ failure assessment scores that Dr. Marek has shown. I mean, it is one of those things where if we replace that automatic acetaminophen order with the vitamin C order, the mortality rates would plummet. We would see such a huge difference. We have the ability to check blood levels. We have the ability to do a very quick urine dipstick looking for vitamin C levels. Okay, so let me just...
Real quick though, Suzanne, I want to add one point to that. Is one of the reasons why vitamin C is so critical is because humans, I think it's humans and gerbils, and then I think fruit bats or something. There's like 3 mammals who evolutionarily, we developed a defect where we can't make our own vitamin C. So we're actually quite unique amongst mammals. All other mammals, when stressed or sick, ramp up production to huge levels of IV vitamin C. And this is well known, yet to this day, in modern times, when we get ill, knowing this simple physiologic fact, we're not repleting, and actually even increasing to the levels that the illness demands. And you're right, it has been going on for 70 years. It's constantly suppressed. And then the story that you told about Alan Smith, it mirrors what happened in ivermectin with my colleague, Ralph Larigo. He took 80 cases to court trying to get judges to give orders to try ivermectin. And as you may know this, he won 40 and lost 40. Of the 40 he won, 38 people survived. Of the 40 he lost, 2 survived.
Yeah, yeah. Well, we have to keep saying it. You do have to keep repeating yourself, Pierre. Please don't stop because you think that it's futile, because I think you've already made a big difference in the news blitz that was about to happen because of this one death that people would absolutely believe. So yeah, I actually did a long lecture on vitamin C, which is available on my Odyssey page. There should be 2 different versions of it. But so when we're dealing with this mycoplasma pneumonia, we call it walking pneumonia, right? So it's because people walk around with it before they realize realize they're sick. So you do have time to actually treat it. It's not one of those things that just takes you out, really quickly. But there's a toxin involved in it, and they named it so aptly, community-acquired respiratory distress syndrome toxin, CARDS toxin, and basically talk about it as the main bad guy in the Mycoplasma pneumonia. So while, it doesn't have a cell wall, it still seems to produce this toxin. And I have a slide for that, and so they may just put that up there. That's my slide number 1 there. An article by Ramasamy and a whole bunch of other doctors. But more importantly, now let's look at acetaminophen. And the reason I want to look at acetaminophen is because we know from my slide number 5 that Mycoplasma pneumonia really requires a neutrophil-driven immune reaction, okay? So that's my slide number 5 there that I'm talking about. You have up a different slide. You have the slide number 6. So actually, sorry, you put up the slide before that. There we go. So we know that we need good neutrophil function. Well, if you back up 2 slides, we see on slide number 2 that acetaminophen inhibits the neutrophil oxidative burst. So as one of the many detrimental effects of acetaminophen, which I'm going to get to more of them in a minute, but it inhibits the neutrophil oxidative burst. Well, what does that mean? Well, we have hydrogen peroxide built up in our neutrophils so that when it engulfs something that doesn't belong, then it's able to actually digest it. And so we need that to happen. And vitamin C actually at high doses will help that build up inside of the neutrophil. So here we have already 2 things kind of working against this child. And then we have here, again, another by Shalabi, which I talked about last week. Acetaminophen inhibits the human polymorphonuclear leukocyte function. So we know that acetaminophen would have been detrimental to her for that reason. Then if we go back to the slide that you had up initially, it's slide number 5. This is just a summary from an article that I read back from 2012 by Lee, that septic patients die more often when they're treated with anti-fever drugs. And that seems kind of strange until you really understand what fevers are and why we need them. But there was a prospective study that looked at body temperature in 63,000 people, and antipyretic treatment was given in 4,800 to 737 patients. And what they found, long and short of it, is that mortality was increased when given acetaminophen to septic patients. And it had an odds ratio of 2.05 for just the acetaminophen. And what that means, if the odds ratio is 1, it means acetaminophen has no bad effect. If it's lower than 1, it means it had a good effect. If it's above 1, it means it had a bad effect. It was 2, okay? So that's a highly significant odds ratio for death in sepsis when given acetaminophen. So when we get to vitamin C, there's my slide. If you go to slide number 7, there's an article that I cite quite frequently by Dr. Gahn, talking about vitamin C deficiency in a university teaching hospital. And this is a really interesting article because, as I show on slide 8, they looked at 2 different groups. They looked at a normal reference group of outpatients, and then they looked at inpatients, and they checked their vitamin C levels to see who was deficient. Now, mind you, they consider subnormal 28.4 micromoles per liter. And I'm going to tell you that I believe it was Dr. Vissers showed that eating 2 kiwi fruits can bring the average man up to 70, okay, that concentration in their blood. So 28.4 is really, I consider that a low level of vitamin C. But even if we go with their low levels being normal, we see that even on the normal reference outpatient people, 141 of them, 3% of them had scurvy level vitamin Cs, 13% had subnormal, and they say 84% had normal. But let's look at the next slide, which shows hospital admission day in Canada. These patients, 149 of them, and again, using their really low standards, these numbers would look much worse if you used, I think, what the standard should be. But they showed that 21% of them were subnormal, 19% of them, sorry, I think I'm getting this wrong because I'm slightly colorblind. Let me just get back here. The majority of patients had subnormal let me look at the deficient ones, less than 11.4 was 19%, and subnormal, less than 28.4, that was 60%. So that's a huge difference between the outpatients and inpatients. The inpatients had much lower vitamin C levels when they entered, but here's the kicker. Anyone who was taking vitamin C on admission had their vitamin C stopped and were not given vitamin C during the admission. And they talk about how these patients had vitamin C levels consistent with what they would call scurvy. And it's not the only study that was done. I'll show you another one, but I love this quote by Dr. Klenner. He says, there are some physicians who would stand by and see their patient die rather than use ascorbic acid because in their finite minds, it exists only as a vitamin. And the likes of Dr. Fred Klenner and Linus Pauling and all the great doctors, Dr. Tom Levy, who's still with us today, who have been crying out with all the evidence in the world over one of the least toxic compounds on the planet. That's also been shown that, salt and caffeine are actually more toxic than vitamin C when we look at the LD50 rates on those, which I've discussed in the past. So it's a very safe thing to give, especially if you just give one dose, then you can check your kidney function, you can hydrate the person. It's an extremely safe thing to do in a hospital, should be done immediately instead of giving these fever reducers. And likely if it was done, the desire to lower fevers wouldn't be there. And these people, they have no clue what a fever actually does in the human body, which actually really upsets me, because if you go, there are two areas where I did a full out research onto what the medical literature actually says. That is using fever lowering drugs in sepsis and infection. And the other one is immediate cord clamping in a newborn. The medical literature is just overwhelmed with what is contrary to what's done in hospitals. Okay, so if you were to look at the medical literature, you will see that it is not a good idea to lower fever in a person that's infected. And you would see that it is not a good idea to immediately cord clamp a newborn, mammalian newborn. Yet, and even the American College of Obstetrics and Gynecology states that the cord should not be immediately clamped. But what happens in most hospitals? Immediate cord clamping, which deprives a baby of 1/3 of its birthright blood and stem cells. It's a disgusting practice that needs to stop, but it's just another area of this eminence rather than evidence-based medicine. And all we hear about the science, and evidence-based medicine. Well, where is the evidence in giving Tylenol? And I really wish that every doctor in the world and all the pharmacists had to go do in-services on what the actual medical literature says, and that in order to write a prescription for acetaminophen in a hospital setting in somebody with a fever, that there would have to be pharmacy approval by a pharmacist that understood this issue, because there's really no reason to do it.
Suzanne, I'm going to make a point there because, one of the things that in reviewing this case, I like what Polly said earlier, that the mainstream media is now not saying she died of measles. But the other thing is, as you know, right, when there's a bad outcome in the hospital, we're supposed to learn from this, right? And there's tons of teaching points, and I appreciate that you're bringing those out, but bringing out that point about Tylenol is critical, just like bringing out, my point about the appropriate treatment of a community-acquired pneumonia. Out of all of the therapeutics studied in COVID, and there's a really great website that is compiled in a consistent protocol of meta-analysis, there's over 70 different therapies that have been shown to be effective to treat COVID. There's only a couple that have shown harm. One was convalescent plasma. There was a trend to harm, but the only statistically significant intervention which actually increased mortality was Tylenol or acetaminophen. And so we have so much data showing treating fevers. And I used to get grief as an ICU doctor when I didn't want to treat a fever. It would go up to 104. You have the nurses running around getting all frazzled, like Dr. Kory doesn't want us to treat this fever. I looked like a criminal because it's so pervasive that you have to treat a fever, and it's a shame because you're right. The evidence does not show that.
No, it doesn't. And when those of us that actually look at the physiology and look at the evidence, we end up, we're the ones that are called quacks and ostracized and villainized. Yep. But, that's okay, because we're just going to keep talking about it because we have to, because this is if they want to put their money where their mouths are, that they're about making the world a healthy place, and hospitals are treatment centers and care centers. If you're actually under a doctor's care, then you would think they should actually care. They should care to make you better. They should care to have the understanding of what their own medical literature says, and to actually question what they're told to do by the powers that be. And that's really, when I talk about it being a systemic problem, the systemic problem starts at medical education, because that's an automatic order, isn't it? Fever greater than 101.5, give fever lowering drugs, whatever. And because why? Because they don't want to have to wake the doctor up in the middle of the night, heaven forbid, right? For a nurse to give an order. So you just go ahead and put a standing order.
It's protocols, and that's the protocols taking over medicine. I think your point that is so great is that I think doctors come in, they're very sort of deferential, right? And they kind of do what they're told. But the problem is they don't question enough. They think that it comes from this, four-lettered society, from this journal. This is what you do. There's this assumption that this evidence has been sorted through and analyzed by the uber experts, the smartest doctors in the world, and through their genius consensus, this is what they have told us to do. And so they do it thinking it's the right thing and not having understanding that these consensuses are often manufactured and literally are driven through the influence of pharmaceutical companies. And unless we start teaching our medical students to question everything, because sometimes it's not so hard. I like what you said. You just start looking at the literature, ask a simple question and look at some papers. You'll find that things that are standard of care in medicine are very poorly supported or often contradicted. Like you said, contradicted. Like you're doing the wrong thing, thinking you're doing the right thing, and medicine is full of that. And I don't know how to fix that.
Yeah. Yeah, me neither. Well, that's why I left my conventional job, is because one of the things they were doing was vaccinating my patients who had almost no white blood cell counts, on chemotherapy, with kidney failure, sepsis in the ICU, a patient I was about to do a kidney biopsy on. And we know that vaccines cause coagulopathies. That was proven a long time ago. So it was just like, that's the wrong thing to do. And all I did was ask them to delay it till the day of discharge, and they wouldn't do it. So that's what created the monster that became me, was because they just kept telling me off that I was wrong. And then I went and actually looked in the medical literature. It's like opening the Bible. We're not supposed to do that. We're supposed to believe the priest, right? But anyway,
I left for the same reason. I want to make one more point on your the deficiency of vitamin C. When I started to develop my expertise in vitamin C, following the work of Paul, and I did some research and some papers, but I was astounded. You can find a half a dozen papers where they've measured vitamin C levels on admission to the ICU. Remember your slide of that hospital day? If you end up in the ICU, they were like literally near zero in almost everybody. And so what I did, this is a little anecdote. I was the chief of the critical care service. I put together a whole sort of overview, all of the evidence, and I made the argument we should start an IV vitamin C repletion protocol on admission to the ICU for these simple reasons. Humans can't manufacture it. All the evidence shows that they are absolutely depleted. It's critical for these four functions. And guess what happened to me? I got a call. I sent it out to the whole service. Within 1 hour, I got a call from my chief, chewing my ear off. What are you doing? You can't do it like this. There's no evidence for this, no randomized control. And he was like angered. And he was a very nice man. He was really angry about what I did. And I was like, what world am I living? I'm just saying we need to replete vitamin C, but it's very hard to change medicine just using common sense. You have to come with the paper showing it, and then they come up with papers shows that it doesn't work. So anyway, I'm believing.
Or you give someone a kidney stone, don't you know, Pierre?
Oh, I hear that all the time. They're dying of multi-organ failure and they're worried about a kidney stone, which doesn't happen.
I know. They actually found with kidney failure, people even did better when they had, and look, Paul Merrick was the chief. And look what they did to him. So you know what happens when we try to get behind vitamin C as just a supportive measure, because we know all the other drugs that would be given during the hospitalization, many would be lessened, and many of them would turn out to be unnecessary.
Suzanne, there's an interesting thing that happened to Paul. So when he started his protocol in his ICU, he had about 3 partners who were running the ICU, and they were largely doing it. All of them were doing it in his ICU. Somebody who had seen an interview with Paul, who worked for Truven Analytics, which is the main data collector for CMS, all of Medicare, they were watching the mortality rates for sepsis at Paul's hospital. And in a year and a half, it went from a national standard of 22%, and it went down to 6.5%. They sent the data to the CEO of the hospital, who shared it with Paul. It was not a study. It wasn't anything. It was just Medicare data. You see sepsis rates are stable and like pretty, conventional all the way around. And then suddenly his plummeted. And yet it's still not standard of care in this country.
Yeah, exactly. There's another thing also to bring up is that, we're talking about the acetaminophen and everyone doing what they're told, but, a lot of parents know the deal with acetaminophen and they don't want it. And when they take their child into even the emergency department, they are absolutely, ostracized and treated very poorly. Often the patient is treated poorly because that parent is refusing a fever reducing drug, because those nurses are so incredibly blinded and they think that the fever is the disease and lowering the fever will lower the disease. They don't realize actually what they're doing. They don't want to hear anything the parents have to say. And so it's really a risky thing to bring a child into a hospital, when you see kind of the trap that you have, and there might be at the end of the trap, there might be something that you need, but you've got to walk through that in order to get the thing that you might need.
Suzanne, you're bringing up a point, because it's not just Tylenol. All of my experience in COVID and talking and supporting families and guiding, especially in the hospital, you refuse anything that
That's right.
think is standard. It alters the relationship to a kind of a contrary one, a little bit of a conflict. And then you can see that the psychology of the physician starts to judge the patient, the family. They're non-compliant. They have their
That's
own
right.
strange ideas of what should be needed. They're not evidence-based. And it really kind of deteriorates that relationship. And I saw really contentious things going. And you don't want to go into a doctor and fight with them. It should be collaborative decision making. You
Right.
should be able to voice your wishes and why. They should hear your rationale and they should support it. But it just doesn't work that way. They like the one-way street. I'm the expert. You do what I say.
That's exactly it. There's a lot of ego involvement, and you don't want to be the topic of the ICU staff in the lunchroom, and that's often what happens. Oh, there's non-compliant people, there's crazy people who don't want to take this drug and want to dictate that drug, and control freaks or whatever. I don't know about you, but I always like those people, because sometimes I would go in and I'd say, well, what do you think is wrong? What do you think the person needs? And you know what? 9.9 times out of 10, that wife or that husband that's been sitting there with that patient for 2 weeks knows what they need, and you do it, and it actually makes your life better. But instead,
They can
yeah.
give you information that everyone misses. I come late to the case. You're right. Go to the source. Go to the wife. Go to the brother,
Yeah.
the son, or the parent, and they will give you the granular details of what everyone's missing. And so and then I get to look like a genius because I figured something out, and I was like, actually, I just asked the parents, and or the wife, and it's like, just ask questions and listen.
Yeah, I hear you. That's amazing. Yeah, well, I don't have a whole lot more to say other than that, I can back up everything I said, and you can probably add to it with more journal articles. There's just piles of evidence to back up everything that we said here today. But I think Polly has this other child that she wants us to discuss, who they poisoned in Rochester, New York. That's a really great one. Holy moly.
Yeah. Oh, well, first of all, thank you. That was fascinating and brilliant to have you both discussing that. And once again, just to reiterate for those at the back that don't hear this very well, this child did not die of measles. So that is categorically proven by our 4 doctors that have looked at this information. So there's that. Right. Let's move on to the devastating story of the little baby girl at 1 year old that had that slew of vaccines. Let's pull up that chart that we did record this story. They bravely, just 2 days after the death of their child, came and told their story. They are desperate for the world to know what happened to their child. And you've both seen very limited. We're still waiting to get the hospital records and various other records to discuss this more. But for now, with what you've got, what are your thoughts on what happened to this little girl, beautiful little girl?
Suzanne, you want to start?
Yeah, well, I saw some very brief information, and something that struck me was that one of the medical issues that was listed was constipation. And I don't know if that was addressed at all, but another thing vitamin C could have very easily addressed and set that child in a much better state to be a recipient for vaccines if you must give them. But so she started out with constipation. I believe she may have had a cold. Was that true, Polly?
Yeah, she had a cold.
Yeah.
The whole family had a cold.
Okay. Yeah. So they have a cold, constipation, and she's in for a well baby visit, which is another thing I think should just be abolished. Well baby visits should be stopped altogether. It's an absolutely ridiculous thing to do. It's only a setup for vaccines, and well babies don't need to go to the doctor unless the mother or the father senses there's something going on. There's a specific reason. These well baby visits are an opportunity to pick up all kinds of things in the medical office. This was one of the biggest places for contagion. So anyway, you have this setup. So anyway, the ground is fertile for something bad to happen in this child. And she has two teeth, and you can see them on the video, two little teeth on the bottom. And one of the protocols is to give a good dose of sodium fluoride onto the teeth. And the mother even said, my baby doesn't need that. She only has two teeth. And she was forcefully told that the baby does need it. Now, did anybody stop and think about this? Like, what's up with these protocols that you have to stuff sodium fluoride into a baby's mouth for only two teeth? And if there aren't teeth for it to kind of stick to, that baby swallowed most of that sodium fluoride. So there we have another poison added to the baby. And then you give it 12 antigen vaccines in 6 different shots while the child is bleeding to a degree that should have alarmed somebody that something went wrong with one of the needles, or maybe the baby has a coagulopathy, or maybe the baby's blood pressure was so high that blood was being forced out of that hole. But that's like, why not just stop and say, okay, let's comfort the baby, let's put a little compression on there. But instead, apparently, she was brutally continuing to give the vaccines. And then didn't you say that, is this true, Polly, that when the police came to assess, the police said that the baby was fine? Did that really happen?
The police said the baby's obviously stopped having a seizure, so it's up to you if you want to take it to the hospital, but
yeah,
it's okay for us.
So again, a well baby visit death. I consider this a well baby visit death.
Suzanne, I just want to point out something on the well baby. I don't want to talk about me here, but it's just an interesting kind of insight because you really triggered something in me. But when I went to medical school, I actually had a plan to become a pediatrician. I had this very romantic view from like Norman Rockwell paintings, you know, benevolent older physician with the young child who looks up to him and he's listening to the child. Like, I literally had this romantic view. When I went to my pediatric rotation, I spent 2 weeks in a pediatrician's office. I didn't know what was going on. These endless patients coming in, they would plot their height and weight and then jab them. And I said, I cannot do this with my life. And the point that you just made about disbanding well baby visits, I was like, well, who's going to measure their chart and weight? I guess that can't be done at home using a development chart. And then if you see something, you know, your child veering, then you go to the pediatrician. Like, you're right. It's a setup just to get vaccines. I'm glad you made that point.
Yeah. I had the same experience. I was at, I think it was St. Christopher's Children's Hospital in Philadelphia. I did a 6-week rotation there. And I remember seeing the well babies come in and they had to look in their ears and that would just set them off. Like every baby came in smiling, every baby left screaming. Yeah. And I just thought, what the heck is going on here? And it was a really kind of mystifying 6 weeks. At the time was mystifying. Now I look back on it and I just see so much that I couldn't have possibly seen then.
100%. I agree with you. I think, thank you for bringing that up because you reminded me of, I was really turned off and I immediately decided I was not going into pediatrics. I had no interest in doing that kind of work.
Yeah.
So to summarize this up, so as Mary Holland quite rightly said, as we did this story, what happened to this girl is disgusting, but it's happening all around the world on many, many occasions. Some parents not even realizing, trusting the doctors that just say it was, well, she was going to die anyway, it was genetic or whatever excuse they give. Can you please speak to our viewers, or at least tell the people watching, because we have a whole load of new viewers now, how dangerous, if you can, I know you both have licenses, you have to protect, these vaccinations are? Or let me put it another way, there is no such thing as a safe and effective vaccine as per the CDC, for goodness sake. The parents are not given any informed consent. These parents had no idea their child could even have a seizure from any of those many shots that child was given. Can you give a few warnings out, please, as doctors?
I mean, I'll start. Suzanne is really the one who's devoted most of her life. I have done the same in the last few years, but I also will have to say that as recently as 5 years ago, I thought vaccines were largely safe and effective. And I have 3 children who are fully vaccinated, not for COVID, but prior. So my awareness has come around. But some of what I've discovered, I discovered after discovering what they did to ivermectin, which is, I think the root of the fraud is at the level of the medical journals. There's what I call an editorial mafia. The journals are controlled by the pharmaceutical and the vaccination industry. So your question is, how dangerous are these? That is suppressed at the journal level. It is impossible to publish objective data, which leads to a conclusion of how dangerous they are. I shouldn't say impossible. You can get them in sort of peripheral journals, but for every paper you get in a peripheral journal, they'll get some big study in a major journal, and then all of the guidelines will say these are safe and effective. And then we also are now aware of just decades of censoring adverse data. So when you ask the question, how dangerous are these? You'd have to ask the question of someone like Suzanne Humphries, who's really looked into all this. And so not only the lack of safety, there's also lack of necessity, right? We know that most childhood illnesses, kind of the mortality disappeared before vaccines ever appeared on the scene. But then you can even go even further back to find the fraud, which is the whole concept of vaccination being a benefit to your health. Well, even if the vaccine works, it should be called into question. These are dangerous things just physiologically at basis is what my impression now is. And then there's other things like they don't take into account the consequences of vaccination. So for instance, this flu vaccine, it's actually I like how Suzanne made that point. It's in the literature. People who get flu vaccines, let's say it slightly reduces their chances of getting vaccines, they're at much higher risk of getting other respiratory viruses. So this blindfold of like, oh, the flu's circulating, we need to circulate for flu. So now you jab them with the flu, and now they're in the hospital a week later with RSV or something else, but that doesn't count as a flu problem. And so it's unfortunately we're in this information warfare and getting real accurate information out on the true risks, benefits, and alternatives. And that's the other thing that I want to talk about with vaccines is that, we constantly are focusing on risks and benefits without enough discussion of alternatives. The other explosion of awareness that I've learned in COVID is, I will tell you, prior to COVID, I didn't think there was much you could do about viral infections. Just supportive care, they're self-limited, let the body fight it. Now I know of dozens of therapies in which you can treat viral infections. And I would have loved to have had a shot at doctoring that girl from day one. I'm sure Suzanne would have. I love that. The oral vitamin C and then you did the IV vitamin C. There's a lot of different antivirals that are broad spectrum. And so, we can treat these diseases, but those treatments, unfortunately, are not profitable. They're always going to be met with the dismissal of insufficient evidence, right? That only they determine what sufficient evidence is. You can bring in dozens of papers and it still doesn't matter. And so, unfortunately, I just think my belief is that vaccines are a myth. And that myth is being supported to this day through a lot of manipulation of the medical literature.
Right. Yes. And I agree with everything you said. I also want to bring in the concept of effectiveness because it's a bit of a joke how vaccine science measures effectiveness. So you would think that they would measure it in all cases by having some sort of experimental animal re-exposed to the actual germ that they're being vaccinated for. But in most cases, effectiveness is measured by antibody production after the vaccine, short-term antibody production. Sometimes if you're lucky, maybe 2 weeks. If you're really lucky, maybe 4 weeks later. The problem with that is that to deal with most infections, whether they're viral or bacterial, we need the arm of the immune system, the cell-mediated arm of the immune system, to be active and robust. And what vaccines do, by and large, except for the live viral vaccines, which still have their problems, but most of the other vaccines are not live. Most of what she got injected with were not live viral vaccines, although she did have at least 4 antigens that were live viral. Most of them are killed and inactivated or subunit vaccines that have aluminum in them and basically set the immune system on fire and set it into the direction of the Th2 rather than the Th1. So they're misprogramming an immune system that's meant to be kept quiescent in a newborn up to 2 years of age. There's a progressive release of the immune system while it's learning about antigens in the world that it shouldn't respond to, while its mother's milk is programming it to tolerate, because it's more important to tolerate rather than it is to react when it comes to long-term dealing with allergies and reactivity. So we have a real problem with how the immune system is programmed with vaccines. But when you look at effectiveness, I know a lot of people that woke up just saying, oh, my kid had 4 whooping cough vaccines that got whooping cough. And we see that quite often. And it's really hard to get doctors to check for whooping cough because they think that it's pretty much gone away. So we have the effectiveness issue, which you can prove with just about every vaccine I can think of that's given to humans, at least to babies and adults against the more common diseases. I'm not going to talk about rabies or any of that stuff that people want to get me into, or Japanese encephalitis, because that's not my wheelhouse. I like to deal with the stuff that's given to babies and children. And when you look at those, effectiveness is wanting, and we have vaccine escape issues and things like that I've talked about over and over and over. So to really answer your question, Polly, is impossible. And you know why it's impossible, because there are no long-term studies on vaccinated versus unvaccinated okay, and I'm talking long-term. I want to talk 20 years, because while Paul Offit and his friends can sit around and talk about how they vaccinated their kids and they're perfectly fine, well, let's look at the chronic disease rates. Let's look at the cancer rates, most of which you're not going to see for between 10 to 20 years after a vaccine has been given. So while they say there are vaccinated, unvaccinated studies, we know that they're an absolute total joke, because they don't use real placebos, or because they only look at one vaccine. But we've never looked at the full, in a formal way, I should say. There have been plenty of informal studies that have looked at retrospectively vaccinated and unvaccinated, both in the same family and not in the same family. And what we see is that, yes, children who are unvaccinated tend to get measles, they tend to get mumps, they can get rubella, they will get whooping cough. Everybody will get whooping cough eventually. Sorry to tell you, whether you're vaccinated or not. It's kind of like COVID. Most of you are going to get it. So the long-term studies in that sense do not exist. And so what we find is that the unvaccinated have a far lower rate of chronic diseases. They require fewer medications. And I think we need to really get that study done. I think that there are millions of people across America who would volunteer their unvaccinated children to be the control group. And I think we need to do that quickly before the control group is steamrolled and vaccinated by law, or by some other coercive means, so that they can't go to school or do whatever they want to do. So we really need to look long-term. We need to look at vaccinated, unvaccinated, but I can tell you, and Polly can tell you, and I think the movies can tell you, that the unvaccinated children by far are healthier in a lot of more meaningful ways, and that there are lots of parents and grandparents who have raised multi-generations of non-vaccinated children, and they have zero regrets.
Thank you, Dr. Suzanne. And we do this, just so everybody listening, we do this because the doctors are not giving you true informed consent. So we've just covered a beautiful 6-year-old girl that was killed by hospital protocol, measles hospital protocol. And then you have a beautiful 1-year-old that was killed by vaccinations, from what I can see, unless someone else can tell me different. I mean, it's just a clear dunk case, if you ask me. And that's 2 beautiful girls that should be growing up in America, they're American children, and everybody should be angry about this. And again, this is happening all around the world as we speak, the over-jabbing of these kids, the death. There's so much death. There's so much death. And on the last trip on the bus, Suzanne, that's all we saw was death, 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 death. And it has to stop. So thank you for being brave, Dr. Suzanne. We lost Dr. Kory. Sorry about that, everybody. What we're going to do now, so when Brian Burrows and I went down to the Mennonite community in Gaines County, we went to the measles clinic. We spent a long time in the measles clinic. It was fascinating. And so Brian's put a 10-minute little thing together on how the Mennonite community were coping with measles. No masks, no plexiglass, no 6 feet apart. So check this out. Thank you, Dr. Suzanne, as always.
Thanks, Polly.
There doesn't seem to be any slowdown in the growing measles epidemic in West Texas.
New numbers show the measles virus spreading like wildfire. Texas, the center of the worst outbreak, now up to 223 cases, nearly double that from last month.
Measles is a preventable disease that the U.S. considered eliminated in 2000 through vaccines. But since late January, the outbreak has sickened more than 200 mostly unvaccinated people in West Texas. The majority are local Mennonites, a close-knit Christian community largely wary of Western medicine.
Vaccines are almost completely effective against the highly transmissible airborne virus. Between 25 to 40% of measles cases require hospitalization.
For respiratory distress and other serious and potential fatal symptoms of measles, which can kill you and which has already killed a child.
One unvaccinated school-aged child in that area died due to measles-related complications.
Officials saying that that child was otherwise a healthy individual, so officials really trying to encourage people to go out and get those vaccines.
Good morning, CHD. This is Doctors and Scientists, and I'm your host, Dr. Brian Hooker. We're going to go right to the situation in Gaines County, Texas.
We really wanted to find out for ourselves what was also going on down there, because the press was so badly reporting this. And we got the great honor to interview the little girl's parents, who were just the most fantastic couple.
There was a tragic death, but as we've known happen in the past, Polly, the media just uses that as propaganda for go get your vaccines, go get your vaccines.
Well, so first of all, you've had a chance to look at the medical records of this 6-year-old girl.
Yes.
Tell us what you found so far.
What I found was that she entered into the hospital and through emergency room on February 22nd. She had a measles rash, and she also had pneumonia. At that point, they diagnosed it as measles pneumonia and bacterial pneumonia as well. So she had what was considered a secondary bacterial infection. We want to bring on Dr. Pierre Kory. Dr. Kory is an expert in emergent care as well as pulmonology. Dr. Kory, you've had a chance to look at the medical records. What's your assessment?
Yeah, so I've done medical case reviews for malpractice lawyers for a good part of my career. And this case was tragic and really had nothing, I shouldn't say nothing to do with measles, but she did not die of measles by any stretch of the imagination. In fact, she died of a pneumonia, but it gets worse than that because she didn't really die of the pneumonia. She died of a medical error. She was recovering from measles, getting a secondary bacterial pneumonia. And let me give the hospital some credit. They correctly diagnosed her. They very quickly on admission realized that she was coming in with a secondary bacterial pneumonia. And I think that was an absolutely correct diagnosis. The treatment was absolutely incorrect. And when I say it has little to do with measles, secondary bacterial pneumonias can happen after any viral infection. And so, this is not, we're all, everyone's grandstanding and all this outrage over this measles. You see the media is going nuts about how everyone needs to get vaccinated. I would tell you just simple, straightforward, correct medical care. We've been treating pneumonias for decades with antibiotics, and this was just a tragic error of an insufficient and incorrect antibiotic regimen on admission.
Even though we've put out that this child was not killed by measles, they are still saying that this girl that died from measles, she categorically did not die from measles.
No, she did not, Polly. They wanted something that fit the narrative. And the narrative is the only way to prevent measles is to take your MMR shot that also covers mumps and rubella. And there is, it's a deadly disease. If you don't take the shot, you will die.
Basically, fever and body aches, sore throat, coughing, and of course the spots.
And how did you treat your children?
With the A and D.
And how are they doing now?
Actually, most of them are doing really well. And we did the IV infusion too. Adenitis, I think, it was so easy. Like, it was not a big deal. We have not found that it's maybe a little bit worse than a regular flu, but it's not impossible.
So we have an 8-year-old daughter, a 6-year-old daughter, 3.5-year-old little boy, and then a 9-month-old little daughter.
And have any of them got the measles? Have they had the measles?
They've all had the measles. Every one of them got it. The first one got a fever, and within 4 days she broke out in the rash. Within a week from when it started to when she was clear, she was back to her normal self, running around, playing.
How do you treat the measles?
We actually just, as soon as we heard that measles was spreading, we started giving cod liver oil. So we had been giving cod liver oil for a month prior to them getting it. I really believe that made a huge difference because all of our kids, from when they started breaking out in a fever till they were past the point of being contagious, was a week max, maybe 8 days kind of thing.
So all of your children have had measles?
Yeah.
And they've all recovered?
They've all recovered. Ours breezed right through it. I mean, they had a couple of days of really high fever, but overall, nothing that we couldn't manage.
And they did not get the MMR vaccination?
They did not get the MMR vaccination. None of our children have had any of the vaccinations.
Okay, so when did he get it?
Well, it started Tuesday, but they fully came out yesterday.
So it's been a few days. And has the cough been?
He's been coughing really bad, and then I think he's got an ear infection as well.
Are you feeding him?
No, I bottle feed him.
Yeah. Well, you're in the right place. So what are you giving him?
I give him silver. I give him cod liver oil.
And do you have other children?
I have 2 more.
Have they had it?
They've both had it.
How old are they?
She's 4 and he's 2.
And they had it and they're over it. And they're doing okay?
Yeah, they're doing good.
All right, so, and you've all had measles? Okay, what was it like having measles?
It was like being sick, just a little bit worse. I was sick for about a week. Some fevers, but nothing too bad.
And how do you feel now?
Great.
You feel great. So you're glad that you've got it?
Yeah.
You had it?
Yep.
And what about you?
Horrible.
You didn't like it? How about you? How old are you, did you say?
I'm 17.
17. And what was it like having measles?
I have a new name for it, miserable.
Miserable
It
measles?
was so miserable. But I'm thankful I'm over it and I'm never getting it again. It was bad, but I got over it, so.
Would you prefer to have got the MMR vaccination?
Oh no vaccinations.
I did want to mention that the Mennonite community has been very vocal to me that they wish people would understand the choice in their mind is not between get sick with measles and die or take this shot that has no side effect. There's a legitimate conversation that I think we need to have. That's what they're asking of me.
How are you feeling? Touch measles yourself?
Yeah, I was pretty achy yesterday.
Yeah.
Did you ever not have measles as a child?
No, I had MMR as a kid.
How many MMRs did you have?
I'd have to go back and look. I don't
But
know.
a few.
Yeah.
That doesn't work then, does it?
No, apparently not. Just wear off.
But you're feeling all right?
Today I'm better, yeah.
You've just spots here or on your body as well?
Just my face. Yeah. They came yesterday afternoon. I was achy. Friday afternoon, achy. Started, and yesterday was pretty achy. Little mild fever. Spots came in the afternoon. Today I woke up feeling good. So, mild case.
You're an amazing human being, you know that? You should know that. Thank God for you.
I know.
We don't want to keep you up with your people.
I'm just doing what any doctor should be doing.
What is your summary of what we've seen so far?
Well, I see no panic.
No masks?
No masks. People are coming in and with their children, with their families. I think that a lot of the reason that we're not seeing panic is because word is spread about what Dr. Ben Edwards is doing, what Dr. Richard Bartlett is doing in this area. And they're realizing that, you do need to treat. You do need to get appropriate help for the measles, but there's no fear. There is really no fear because of the cases that have recovered. You know, there have been over 200 cases of measles in this cluster in West Texas and eastern New Mexico, and those people are recovering. So you're not hearing about the recovering. You're not hearing about people getting better. You're not hearing about the rashes going away. You're not hearing about the cough go away. But that's actually what's happening, and I think that's what we're seeing on the ground here.
You know, there's such a community effort. It was so beautiful to see. And what was driving it was love. Love your neighbor as much as you love yourself. I saw that on display this past 72 hours. So there are so many thank yous that I want to say to that community. It has touched me in my heart, and I'll never forget it.
I'm so grateful to you and to Brian Hooker and to Brian Burrows braving dust storms to get to West Texas to interview these parents, to meet Dr. Ben Edwards, who is treating other children, and really see on the ground what's happening. And it's very, very, very different from the mainstream narrative in every way.
This and all CHD TV programming is made possible by generous support from viewers like you. Please consider making a contribution today to keep our programming going strong. Thank you.